Hi, good afternoon. I think it's very difficult to speak after the lunch. I wish you stay awake. At first, I'd like to thank Dr. Mohammed for his kind invitation to share the experience here in this prestigious event. This is my pre-resume declaration. I have to declare I don't have any conflict of interest from this lectures, and I don't have any direct sponsorship to me regarding this issue of these lectures. This lecture is about dento alveolar trauma. I'd like to thank Dr. Mohammed and Dr. Wael for paving my road in these lectures. Why you are here? Do you see cases like this? Anybody here see people like this? If you are here, you are in the right place. I wish you enjoy and not like these people after these tough lectures. Traumatic injury in the teeth, it can appear to the teeth itself, it can appear to the bone, or it can be mixed like together. Let's define the dento alveolar trauma. Dento alveolar trauma, it's injury limited to the teeth and supporting structure of the alveolar. It can be isolated or associated with a basal bone. Okay, usually it can come from road traffic accident or it can come from sport. One of the very important things we have to diagnosis starting with history, clinical examination, vitality test, and radiological assessment. Regarding to the clinical history, one of the most important things you have to identify the patient's personal history, medical history. It's very important. Why? Because this is determined later on how you can make a maintenance, how you can make a proper aftercare for the patient. Previous dental history, the patient has a dental trauma, has a dental history before you start to tackle. History of trauma, when, how, and where. It's very important to discuss roughly the history of trauma, when and where the accident. This is very important. Like Dr. Mohammed, I don't like to repeat. Very important things regarding to the preschool child. You have to exclude fall injury and the child abuse. It's very important. And if you have a fall trauma, this is very important to check the child vision. In the school age, usually it's from sport, and it can be from fighting, or it can be from auto accident or seizure. So you have to be excluded during your management. Trauma can be direct trauma or indirect trauma in the chin, which is considered one of the very dangerous trauma. Trauma, mechanism of trauma, this is one of the oldest trauma without seat belt. Nowadays, a lot of people, they are wearing seat belt. When I start my residency, a few people, they are using a seat belt. So we have a lot of road traffic accidents. Another very important injury, we see it a lot nowadays, like this whiplash injury from improper type of seat belt. And usually we see it a lot regarding a lot of trauma. The patient is holding mobile like this and he receive a trauma. So clinical examination, it's a must. So I like Dr. Mohammed's kits because one of the important things which is considered a third eye, you should use your palpation, you should use your finger to fix and see extraorally and intraorally to check the lacerations, abrasions, to see asymmetry. This is very important things. And you should check the mouth opening. The intraoral examination, it's a must for this examination. Inspection, it's a mandatory. Usually in some cases we can see something like a step. It can result in malocclusions or something. It's considered one of the very dangerous size like sublingual hematoma. Sublingual hematoma, if it can left untreated, it can suffocate the patient. Okay, one of very important things, if you see a case like this, you should ask where the tooth. The tooth can be inside the lung. It can end with lung abscess, like this case. Can mandibular fracture kill the patient? If you have bilateral parasymphyseal fracture, like in this case, this patient has been hit by a horse. What happened exactly? You have this anterior segment that will fall back and the airway become very, very small, and the airway become like this. The patient cannot breathe. If you don't save the patient immediately, the patient can die from this, like this case. Vitality test is discussed by my friend Dr. Wael. I don't like to repeat it. This is very important to know the prognosis of the tooth. Another important things you should consider before you do any treatment for trauma patient is anti-tetanic serum, especially if you have a road traffic accident or even sport trauma. It should be considered. Soft tissue debridement is a very important and very crucial. Like this case, we do it in Alexandria University Hospital. You see this patient with proper debridement, you can end with very good result. Radiological assessment is very important, especially for the medico-legal issues. You can check the root formation, the presence of root fractures, the periapical radiolucency, and very important to check the tooth. In some cases, there are tooth fragment, it can fall inside the lip wounds, inside the wound itself. Injury to the supporting periodontal ligaments, degree of intrusion and extrusion, discussed by my friend Dr. Wael. And another very important issue, we see it in our patients. Some patients come with pain in the teeth and pain in temporomandibular joint. It can be from concussions. We can treat this patient with laser biostimulation, as I will discuss later on. And size of the bulb, it's very important. We can make diagnosing using different stuff like conventional X-ray, like panoramic X-ray. Usually it's one of very easy. I advise my resident, advise my colleague how to check. Just put the X-ray, put your finger all around and check if there are any trauma. It can be very easy for diagnosed. Another sophisticated stuff like 3D X-ray, it can be helpful, especially if you have aggressive trauma. One of the very important things, you have to check the condyle. If you have trauma in the condyle, especially if you have patient fall in the chin, never make any suture in the chin unless you are making sure there are no condylar trauma. If you have condylar trauma, what happens? The occlusal the patient will have anterior open bite, and especially when the patient is young, the disaster, the growth center, it's destroyed, and the patient will end with deformity, dentofacial deformity. It can last forever. Okay, do you know this person? For me, I like cartoon. This is Andy Gamp. There are no chin for this person. Exactly this is what happened when the patient received the trauma in the chin during the growth. Okay, if the patient is underdiagnosed, this is exactly what happened. What's the problem of this patient? This patient can stay till it will become adult. Okay, usually this patient is complaining with snoring and obstructive sleep apnea. Usually it's called ankylosis of temporomandibular joint. We have to remove all this callus and make reconstruction of this stuff. Usually I prefer to use costochondral graft for these cases. And in some case you will get hypomobility in temporomandibular joint, and usually it can be unilateral cases. And if you see the antigonial notch in the mandible, it's gone already. This is hypomobility. See, the chin, it's going very back, and the airway is very narrow for this gentleman. Another case. So it's one of the very important things for the children. You have to check the condyle. Trauma can be to the teeth. It can be classified according to the Ellis classification into several classes, starting from enamel fractures, enamel to dentine, crown. Trauma to the teeth, and teeth can become non-vital. Tooth lost as a result of trauma, it's called avulsions. Fracture to the tooth with or without loss of the crown. Displacement without fractures. Fracture of the crown in mess, and the fracture of the deciduous teeth. All these variant. I go fast. I think Dr. Mohammed and Dr. Wael will cover this stuff. Very important thing to check the chipped. It can become inside the lip, and can provide, and can the patient later on can get very ugly wound and very ugly scar later on. So you should consider cleaning of these enamel dentine fractures. This epixification discussed by my friend Dr. Wael. Class 4, tooth become non-vital like this. Avulsions, tooth it's gone outside. Root fractures. tooth displaced like this, okay? And this is considered a dento alveolar fracture. What's mean of dento alveolar fracture? You put your finger and the tooth is moved with the alveolus itself, okay? Fracture in crown in mass or its displacement like this. Injury to the primary teeth, and in some time injury, it can affecting the permanent buds of the other teeth. One of the important things is treatment to heal. Time is very crucial. You should consider the timing of treatment and saving of the, this is the rule of the awareness of the sport dentist. They should aware everybody in the field. This is, I get it from my kids' school. We have several first aid for the teeth. Patient instructions should be considered. Okay, we have all these types of the treatment. Today I'm going to tackle the dento-alveolar trauma. Alveolar fracture, what's mean of alveolar fracture? Any fracture in the body, we have several steps for treatment. The first step is called reduction. I should reduce it to the accurate place. Then the second step is called fixation. Reduction can be either be closed or open. What's mean of closed? Without any opening and incision. Sometimes it's enabling me to do this closed reduction without doing anything. And sometimes I should open. And fixation, it can be non-rigid or rigid. I can put something on the tooth, it's called splinting, or I can put something, it's called plating on the tooth, like we stated later on. How we can choose? What do you think? Which is better? Most important thing to choose before you do any treatment, you should discuss, is it isolated or basal bone fracture? It's isolated dento-alveolar fracture, or these are vital or not. I do closed or open reduction. I do closed. I do internal fixation or splinting. Okay, this is from our Egyptian heritage. This mummy is containing wiring of using gold wires. So the idea is very old. We have several types of splint. It can be acid-etched composite splinting, interdental wiring, vacuum formed plastic splint, arch bar splint. This is my preferred, and it's considered one of the emergency in oral and maxillofacial units. Okay, more rigid and longer stabilizations. One of the important things you should consider when you put any splinting is the musculatures. This is very important things. You shouldn't work against the musculatures, or you will feel a lot of pressure on the splint, and a lot of pressure, it can lead to failure of your treatment later on. This is how we can fix, this cartoon it will show us how we can fix an acid-based, acid-etched splinting. Regarding to the fixing, I should guide it by the occlusion to maintain the normal occlusion of the teeth. This is the most important thing. And the normal musculatures of the face. Stabilization for dento-alveolar, it depends on the if I have mobile teeth, it can from 7 to 10. If I have avulsion, it can 10 days. If I have alveolar fracture, it can be increased up to 6 weeks for mobilizations. Like this case, this is closed reduction. I will push it with my finger, and I give the patient adequate anesthesia. Usually, I prefer to give blocks. I don't like to fill this area with adrenaline. Why? Because it will decreasing the healing capacity later on. Like this case. Now it's reduced. We're using arch bar. This is wire. One of the important things, you should consider safety, and usually I prefer to wear a double gloves with different color, because this puncture using this wire, it's very dangerous. I have one of our colleague in maxillofacial in South Africa get HIV from these wires. So the protection is mandatory. We will get the arch bar. The arch bar containing clamps. We put the clamps upward. It should be like this, upward. Why? Because later on I can make something, it's called IMF, internal maxillary fixations. Usually we make it from 6 to 6, from the first molar to the first molar. And it's very important to tighten it. This usually we tighten it to the clockwise, and this is a universal code because if I am going to remove it, I remove it anti-clockwise. And I bend this accurately to prevent the patient from getting more trauma later on. This wire, usually we use some curette, Mitchell curette, to push this wire underneath the cingulum of the tooth. It's above on the root. We put one wire above the arch bar and the lower is below the arch bar. And usually I will make stretching to the root wise during my work. It's this way, it's considered a simple way for fixing dento alveolar trauma. Usually I will prefer to make cutting in the end of after I fix it all. Why? Because I use this wire for method of retraction. Then you bend all this wire toward the midline, and you are avoiding of injuring the lips of the patient later on. This is a classic simple case in a dento-alveolar trauma. This is called closed reduction and non-rigid fixations. Okay. Like this case it's hit by a ball, this adolescent, sorry. What do you think about this case? I am not able to reduce it without opening. For this case, sorry for bad photography, I prefer to make an incision, big incision, and I don't like to get too much dissection, just I see the fracture, I fix it with a plate, I get the occlusion, that's it. For this child. In this I will make open reduction and I will make fixation with 1.5 millimeter plate. Okay, I can go fast.
And 5 minutes.
Okay, great. Let's come for this last case. This case, sure, I will. Sorry. I put plate in this case, and this is after. Basal bone can be included, can be used cases like mandibular fractures, like this case. Mandibular fracture can be favorable or unfavorable, like this stuff. Usually in mandibular fracture, I am guided with the occlusion and with the lower border. This is IMF, how we can fix the mandible and maxilla together. This is a rare case of symphysial fracture. This is open reduction, one of our oldest case. I use wire for fixations. This is mandibular angle. Here see the dissection of the nerve. This is badly displayed case. This is extraoral. This is mandibular angle. See, this is a nerve. See, this is children. In children, the bone is very forgiving. Arch cable, it can be enough and can get very good result. This is gunning splint. We can use circummandibular wiring for this. This is one of the, it's called bucket handle, like this, in edentulous ridge. In this case, it's not enough to put, you should put 2.4 reconstruction plate. And this is closures. Leave forward in the middle face. We have 1, 2, 3. We can using this software to help us to plate accurate plating. Let's come to my last topic, biostimulation. I use laser to change in the cellular level. It can go to change the ADB from ADB to ATB, and this can be promote the healing for the patient and can decrease the pain of the patient and can decrease the edema later on for the patients. Okay, this is the effect of diode laser. Like my colleague early in the morning speaking about the peri-implantitis, I use it for trauma. Laser therapy can affecting the cytochrome C oxygenase. It can affect secondary for release of nitrous oxide, and clinically it can improve the wound healing and the inflammatory process on this. Like this gentleman, he has trauma and he cannot open his mouth. He is fighting like this. After doing the biostimulation, low-level laser on the masseter muscle, he can open like here. See how it can improve. This is a protocol. I use it. I use continuous mode. Okay. Thank you for your time. This is my contact. Thank you.
Thank you very much. Are there any questions from the floor?
Okay.
Gentleman, very simply in front.
Sure.
Could you just wait for the microphone?
I wait for your questions.
Hello. Thank you very much. Very nice talk. Can I just ask you a question about the extraoral open reduction of the mandible?
It's very old.
Why did you have to do this?
It's very old. This is an old case when I was a resident before 14 years.
Okay.
Nowadays, I never use it. I never make extraoral incision for a mandible.
I expected
It's
that.
considered a crime now.
Yeah.
Okay.
Any more questions from the floor? Yes, could you wait for the microphone?
Thank you. Please, the diode laser for biostimulation to reduce the pain and to reduce the trauma, where you put it?
It
The
depends on
trauma.
the trauma site. Usually, I put it in the trauma
What
site.
kind of it is?
I use a handpiece specialized
Handpiece.
for this. If I have the special handpiece, it's fine. If I don't have the special handpiece, I use a non-contact mode with a regular fiber.
Regular fiber.
Yes. And I try to make a tuning in the spot size.
Thank you very much.
Welcome anytime.
One more quick question. a few questions.
You're obviously using the 800 nanometers diode.
Yes.
If you were to use 980 like the one I use, what handpiece would you be using with it and on what settings?
Usually biostimulation, it's we call this cold laser or low level laser. Usually our parameter, it's less than 0.5 watt. This is usually, and depending on the handpiece you have it. I can use it in contact or non-contact mode.
I use the bleaching.
Bleaching, it's fine. It's fine. You can use either single tooth or single arch. You can use for single tooth to just touch a triggering point, or you can use, if you have a bleaching arch, you can insert it here. It can be fine.
But I have noticed that I don't get results unless I start using it on 2.0 watts.
This exactly because you have your machine, maybe the laser, your machine is slightly old. Are you sure you have the 2 watt, it's real? You measure it or no?
What do you mean I measured it?
Maybe the laser machine, the energy, it will decrease.
No, it's maintained. It's maintained. The machine is maintained. But when you use it on anything less than that, there is absolutely no detection of heat at all.
I know. The idea of laser, the patient will not feel heat. The patient tell you, I feel improvement.
But the designated programs on the 800 nanometers, you do feel heat from the handpiece slightly.
No, not on my cases.
I tried 2 different machines.
Not on my cases. I just make a light touch. That's it.
Okay, gentlemen, maybe a chat for the end of the symposium. Okay, thank you very much for your talk.
Welcome.
Let's move on to our next speaker.